Okay, so ischemic heart disease manifestation. Remember what ischemia is? It's a restriction of blood flow to tissues. Can't get oxygen. Break it down. No cellular metabolism. Generally caused by problems with blood vessels. Damage to tissue results. So chest pain due to ischemic myocardium is secondary to coronary artery narrowing or spasms. No myocyte necrosis, so no death. Stable, usually secondary to atherosclerosis, greater than 70% occlusion, or hiding is occlusion typically, hiding or covering. Exertion, chest pain in classic distribution, usually with short-term depression on ECG, resolving with rest or nitroglycerin. That's an easy one, nitroglycerin arrest. Vasospastic. Prinzmetal or variant occurs at rest, secondary to coronary artery spasm. Transient ST elevation on ECG. Smoking is a risk factor. Hypertension. Hypercholesterolemia are not. Triggers include cocaine, alcohol, triptans. Treat with calcium, channel blockers, nitrates, smoking cessation as well. Unstable, thrombosis with incomplete coronary artery occlusion, depression, T-wave inversion on ECG, but no cardiac biomarker elevation. Also, increase in frequency or intensity of chest pain or any chest pain at rest. Coronary steal syndrome. These are distal to the coronary stenosis. Vessels are maximally dilated at the baseline. Administration of vasodilators, such as dipyridamole, hope I said that right. Regadenosin dilates normal vessels. Blood is shunted toward well-perfused areas. Ischemia in myocardium is perfused by stenosed vessels. Principle behind pharmacological stress tests with coronary vasodilators. Ischemic heart disease manifestations. Death from sudden cardiac death, death from cardiac causes within 1 hour of onset of symptoms. Lethal arrhythmia, like ventricular fibrillation. So you need to fix the in order to confirm that it does not lead to cardiac death. Associated with CAD up to 70% of the cases. Also hypertrophy, dilation, hereditary ion channel polyneuropathies, long QT syndrome, Brugada syndrome, prevent with ICD. Chronic ischemic heart disease, progressive onset of heart failure over many years due to chronic ischemic myocardial damage. Myocardial infarction, most often due to a rupture, coronary artery, atherosclerotic plaque, acute thrombosis, increase in cardiac biomarkers like CK-MB, CK if those are typically at 72 hours. Troponins are also diagnostic. Segment elevation, myocardial infarctions. And transmural infarcts, full thickness of myocardial wall involved. ST wave elevation, higher amplitude on the ECGs, and Q waves. Non-ST segment, subendocardial infarcts, subendocardium, especially vulnerable to ischemia, and you might have a ST wave depression on your ECG. So here, ST segment, Here it's up. ST depression for non-ST segment. So there you go. Evolution of myocardial infarction. Commonly occluded coronary arteries. Symptoms: diaphoresis, nausea, vomiting, severe retrosternal pain, pain in your left arm, jaw, shortness of breath, and fatigue. So just in case memory escapes us, the anterior interventricular branch, left coronary artery, LAD, or the anterior descending branch is what it's called, is a branch in the left coronary artery. Occlusion of this artery is often called the widowmaker infarction due to a high death risk. So there you go. And then, so that's your LAD, your left anterior descending artery, the widowmaker. So you die. The right coronary artery, right here, an artery originating above the right cusp of the aortic valve at the right aortic sinus in the heart. Travels down the right coronary sulcus toward the crux of the heart, and then the circumflex artery branches off the left coronary artery and supplies most of the left atrium. The posterior and lateral free walls of the left ventricle and part of the anterior papillary muscle. The circumflex artery may give off a variable number of left marginal branches to supply the left ventricle. So within 0 to 24 hours, you get Euclid artery, infarct, dark mottling, pale with a tetraxolium stain, light microscope, early coagulative necrosis, release of necrotic cell contents into the blood, reperfusion injury associated with generation of free radicals leads to hypercontraction of myofibrils, increase in free calcium influx. Complications: ventricular arrhythmia, heart failure, and cardiogenic shock. Here, if you see some blockage, you'll see a 95% blockage here. And then this is what happens. You put a stent in there, and everybody lives happy. Blockage reduced to 0. And you have 1 to 3 days. Extensive coagulation, necrosis, tissue surrounding the infarct shows acute inflammation with neutrophils. So if you see neutrophils, that's what you should be expecting. Post-infarction fibrinous pericarditis. Again, that is your complications. Light microscope. 3 to 14 days, your heart will have macrophages, then granulation tissue at margins. You'll have hyperemic border, central yellow-brown softening, maximally yellow and soft by 10 days. Then you have free wall rupture, tamponade, papillary muscle rupture, mitral regurgitation, again the mitral being on the left side of the heart between the left atrium and the left ventricle. Interventricular septal rupture due to macrophage mediated structural degradation. Left ventricle pseudoaneurysm, but there is a risk of rupture. And then 2 weeks to several months, you might suffer the Dressler syndrome, heart failure, arrhythmias, true ventricular aneurysm, and you have a scar. Gray-white this time, as opposed to just yellow. Myocardial infarction. So obviously we're going to get a question on these on MI. In the first 6 hours, ECG is the gold standard. So cardiac troponin rises after 4 hours. This is definitely on the test. And increases for 7 or 10 days. More specific than protein markers. CKMB rises after 6 to 12 hours, peaks at 16 to 24, and is predominantly found in myocardium, but can also be released from skeletal muscle. Diagnosing reinfarction following an acute MI because levels return to normal after 48 hours. Here you go, 6 to 8 hours. And here your troponin peaks, and CKMB tends to peak a little earlier. Large MIs lead to greater elevations in troponin 1 and CKMB. Exact curves vary with testing procedures, so this might look different for each one. ECGs changes can include ST elevations, ST waves, depressions, hyperacute T waves, T wave inversion, left bundle branch block, pathologic Q waves, or poor R wave progression. Then ECM localization, infarct location, anteroseptal leads with ST elevations or Q waves, V1 minus V2, antero-apical, distal LAD, that's going to be, that's your left atrium defect, by the way, V3 minus V4 leads. These are your leads. So I know on the test they'll ask you, these are probably the two most common. They'll ask you, they'll give you some infarction location, or they'll tell you some lead with elevated STs or Q waves. And if you can relate this row to these rows, you'll get the answer right. So lateral is AVL, inferior is AVF, 2 and 3, posterior PDA, you'll get a V minus V7 minus V9. So those are your leads that you would put on for your ECG. And then you have myocardial infarction complications. Here you have a cardiac arrhythmia, occurs within the first few days. Post-infarction fibrinose occurs 1 to 3 days after the MI. You get friction rub. Papillary muscle rupture, 2 to 7 days. And this is a picture of it right here. It's pretty ugly. Muscle rupture, increased risk due to single blood supply from posterior descending artery. Severe mitral regurgitation. You have intraventricular septal rupture, 3 to 5 days. Increased oxygen saturation pressure in the right ventricle. Ventricular pseudoaneurysm formation, 3 to 14 days. Looks like this. Free wall rupture, basically. This wall ruptures. Free wall rupture, there he goes. And then C might look like this. That's a bad thing. That looks like a tough heart. 2 weeks to several months after MI, bulge with contraction. Dressler syndrome. That's going to be your several weeks after the MI, autoimmune phenomenon. And then can occur in the primary, secondary to left ventricle infarction, VSD, free wall rupture, papillary muscle rupture with mitral regurgitation. These are all very similar, just when they occur. And then finally, the acute coronary syndrome treatments, unstable angina, anticoagulators like heparin, make sure you know that. Antiplatelet therapy like aspirin, typically daily as soon as it happens. ADP receptor inhibitors, beta blockers, nitroglycerin, morphine, reperfusion therapy, most important, percutaneous coronary intervention preferred over fibroanalysis.